We'll now be transitioning to the Q&A portion of our program. If you have not already done so, please submit your questions in the Q&A box. So our first question from the Q&A box is from Belinda Moore. What about women using Libre? Does time and range apply to those using Libre as well as Dexcom Medtronic? As we know, Libre is often inaccurate. And I think a related question is, could both speakers please clarify what CGMs were used? Dexcom versus Medtronic versus Libre. I'm interested if there was any significant differences in outcomes depending on choice of device. Great question. Who would like to answer that? Dr. Meek, would you like to start?
I will start us off, that's fine. Thank you very much, Belinda, lovely to hear from you. So we used in the concept study Medtronic devices. Obviously, that trial started quite a number of years ago, quite many years ago, in fact, and so CGM equipment has obviously changed a lot since then. At the moment, we have no very good data comparing different CGM equipment in pregnancy. The study that we've talked through is really one of the only ones with the scale of outcome data available as yet, although I'm sure there will be more to come. So in a sense, we can't give any definitive answers about this. As Libre becomes a bit more widely used in type 1 diabetes in pregnancy, I expect we'll see a bit more to that. From my point of view, I think one of the issues with Libre is the tendency to read a little bit differently overnight, and particularly to sometimes underread. And I think there have been plans in future generations, if you like, of Libre to address that. However, from an analytical point of view, it's always going to be very difficult for the CGM devices to perform excellently at such a low concentration. And I think, as time goes on, I'm sure that ability will improve in Libre, but also in other equipment as well. I don't know if Rosa would have anything to add there, or Denise.
Rosa?
Yeah, yes, I think that's really a great question. And in practical terms, we can only use the same times in range for all the CGMs. But maybe qualitatively, we can do some appreciation. This paper that was published several months ago from the group from Copenhagen, where the Libre, especially in the night, as Claire has mentioned, had a higher rate of low values. I think we can qualitatively accept, let's say, different times in range for women using Libre and having a good higher rates of low values at night. But that I think at the moment this can just be a qualitative appreciation. We cannot use different cutoffs or different percentages for women using different sensors.
Right. I think, but we all obviously have to make sure that they're not having hypoglycemia unawareness and not feeling the lows, right? That they're not true lows. And the Swedish study, if you recall, where they were comparing real-time CGM to Freestyle Libre in an observational cohort study, found increased time below range. And so we don't really know if it's because they don't have the alarms. So I think once the Libre, everyone's using with alarms, I think we'll also be able to feel more confident that those who are not using alarms were not missing hypoglycemia because they had more time below range without the alarms. Okay. Could both speakers please, oh, that was it, from Sarah Mart. Question from the chat window. On the traditional clarity reports for Dexcom G6, you can set time and range in 5 milligram increments only. Do you suggest setting 60 to 140 or 65 to 140 to look at our time and range?
So I would say that would be a question we would need to take up actually with Dexcom. And it seems to me that actually as the pregnancy community, perhaps we should be doing that. I think if we have a national or an international approach or a consensus statement suggesting it should be 63 to 140, then, perhaps we should be saying, can you change Clarity to allow us to do that? I'm very happy to approach Dexcom to do that, but perhaps if we all did, it might carry even more weight.
Thank you. Would you have the same goals for time in range and target range for women with pre-existing type 2 during pregnancy? Rosa?
Well, I think we know that the consensus was not so specific for women with GDM and type 2. I think the targets should be for the moment the same ones, but we clearly can aim to higher range of achievement. The targets are the same, but I think it's easier and it should be doable in most cases to have not just 70% time in range, but with not so much difficult, we could achieve 80% to 85%, probably. That's just not, we don't have numbers to support this, but we know that those women has less labial diabetes.
Mm-hmm.
So at least we should have the same targets, but
Right.
probably better scores.
Right. Yes. Thank you so much.
I think it's also fair to say that women with type 2 diabetes are an extremely broad range of people in terms of the duration of their diabetes. There'll be people who've literally only just developed type 2 diabetes, whereas there'll be other people who've had it for many years. And that, I think, causes quite different baseline glycemia when you're entering pregnancy. We do see that, of course, with women with type 1 diabetes, but most of them have a higher degree often of education and awareness on entering pregnancy, which isn't always the case for many women with type 2 diabetes who may have just been recently diagnosed. So I think all of that needs taken into account as well when thinking about individual patients.
Right.
I would like to add something that's subjective appreciation, but I think that if it can be safely achieved, we should really aim for higher higher percentage of time in range in women with type 2, and not be comfortable with just 71%, let's say, because we know those women have higher risks during pregnancy, not less labial diabetes, but higher risk, according to whatever it is, inflammation, obesity, or whatever. So let's say that if we can safely improve the glucose control as much as we can do this part. So if there are no special problems of hypoglycemia or whatever, this can happen in women with type 2. But if this is not the case, we should aim to really improve as much as we can to help them to have as good as possible glycemic control during pregnancy.
Yeah, excellent points from both presenters. Thank you so much. From Rana Al Musa, why is the second trimester in concept trial starting from 24 weeks as per table share by Professor Rosa? Rosa?
Is not a beginning there, is the point where we had the measurement. So I refer to it as second trimester, is just a couple of weeks representing the second trimester. And the same for the third.
Right. It just so happens those were the weeks that we chose to represent. That's right. David Sachs, do you envision any role for CGM for management of gestational diabetes? Claire?
Well, so this is a very interesting and topical question for us here in the UK. We have had access to CGM for women with type 1 diabetes for some time, and that's increasing, I think, in its scope. But more recently, we've also had the opportunity to apply for funding to use CGM in women with gestational diabetes who are on a basal bolus regime, so who are taking insulin regularly. So from that point of view, we're very much learning about this, I would say, on our feet in some ways. I think there are huge challenges to using CGM in GDM. I think much like the type 2 diabetes situation, many women are testing for the very first time. They're thinking about food choices for the very first time. It can be in some ways an overload of information to suddenly introduce CGM into that mix as well. And I have other concerns also that you may end up, as we've alluded to before, having low levels overnight, which can to some extent be normal in pregnancy, but which might change your treatment. So you might actually be tempted to reduce your insulin because you're aware of those low values overnight. And you could argue, we don't have clear evidence that that's in patients' best interests. So I think there's still a lot of work to be done, establishing, first of all, how we can best use CGM in GDM, and secondly, the targets that we might be aiming for, probably higher still than we could get in type 2 diabetes, but also I think how this is if it's going to be beneficial actually for mums and babies in this scenario. I mean, obviously all three of us here are very positive about CGM use in pregnancy, and I'm hopeful that we will be able to find that it's beneficial in GDM, but time will tell. Thank you.
Thank you, Claire. Rosa, do you have anything to add to that?
No, I think, of course, there are the pros and cons of overload of information and so on, but I would say that probably the pros would be more than the cons. But
yeah, but we're still awaiting good evidence to answer all those questions. I agree. So I have another question for Claire. Were you surprised about the predictive capabilities of HbA1c in the study, given its many flaws in pregnancy?
Yes, thank you very much, Denise. So my background is actually as a clinical chemist, in addition to being a physician. And so we have been told for many years that HbA1c is not very reliable in pregnancy. There's many limitations. The red cell turnover is so different and so forth. So I was really surprised actually to see how well HbA1c performs. And I think it's hugely helpful actually, because of course we've been using it for many years and it's available in every hospital really, almost internationally. So I would take great comfort actually from the fact that HbA1c does work really well actually. And I think you can think a little bit about why, why does it work so well? And I think one of the things that we might have been considering a weakness could actually be a strength. So the fact that you get really up to about 12 weeks representation in your HbA1c makes it actually in some ways potentially quite a good summary measure of your glycemia over a period of time. And of course, we know in pregnancy, that's relevant, isn't it? It's not just 1 week, it's not just 2 weeks, it's the sort of gradual effect of hyperglycemia over many, many weeks that causes these outcomes.
And Camille Powell is asking a question. How frequently do you tend to check A1C in pregnancy in patients using CGM? Rosa?
that's a good point. My usual practice is to measure it probably every month. Probably not needed, I agree, but it's what we are doing now. I don't know what other people are doing. Maybe this is continues to be a consequence of of earlier times without CGM, where we had all these glucose measurements, but you were never sure of the performance of the meter or the times where you were not measuring. And having hemoglobin A1c was very reassuring to have it. I am doing every month, but probably we could do without it.
Yeah, so given that you have time in range and time above range, do you even need A1C?
Well, you could argue that for prediction, I don't know, for prediction, that's great.
Yeah.
But and the main point for having time in range and time above range is not just prediction, but improvement of outcomes. So I am not so unhappy that the prediction of time in range and time above range was not better, but their real value is to improve outcomes. And the other point here may be a weakness of our studies that we have just measured the CGM values in 1 week, because it was the period where we had these values for the control group. And maybe I would say that probably the potential of the timing range is better than what we have seen here. At least it is like this, but maybe it's even higher.
Right, if we had longer CGM than just 6 days, right, of course. And I have another question for you, Rosa. What is your interpretation of the association between time below range achievement with pregnancy outcomes? It was surprising, wasn't it?
Yeah, that's intriguing. It was already apparent there in the bivariate analysis, and it was even stronger in the multivariate ones, where the only significant associations for timing range were for the low values. So first of all, I think this has to be confirmed. But if we have to believe what it points, and I think an important point there is that the odds ratio was quite strong, so probably means something. My interpretation is that this means that low glucose values, let's say like this, are good for pregnancy outcomes. We can accept this, but if we have to translate this into clinical practice, the problem is how you or pregnant women go there without additional risk. So I think it's pointing that low values can be good. We know they are physiological in pregnancy, those low glucose values, even if the target the target values for pregnancy more or less are adapted to these low physiological values, but maybe they should be somewhat lower or have a higher timing to be the time below range, maybe be higher than 4%.
I think
they point to this direction, but this is not a definite proof.
Right. And we used the Medtronic, which should have been accurate under 4. We didn't use the Libre, so we can't say, oh, it's because it was inaccurate.
Yeah.
Okay, I think we have time for one more question for Claire, Dr. Meek. Measures of glucose variability had no association with pregnancy outcomes or were not independently associated. Do you think that therefore they have no role in pregnancy outcome prediction?
Well, I think that's a really interesting question, Denise. And actually, as you know, there's been lots of work outside of pregnancy showing variability is really important, longer term variability in HbA1c and so forth. So I wouldn't be surprised if actually this is not a story that we have the entire answer to here. It may be that variability is really important for other things. I think we all know from clinic that actually variability can make control harder. We know that it can make insulin dosing more difficult if there's very erratic levels. And so I think that we certainly didn't find any obvious evidence of variability contributing directly to outcomes irrespective of the glucose concentration, but I think we may find it is relevant to control overall.
And I think the last question from Rana Al Musa, which glycemic control of a trimester matters more regarding LGA? Is it the second or the third? Rosa?
I would say both. Initially the second. I think the third also contributes. And there we can have the exception of women with had very inadequate control in the second trimester with very large overgrown fetuses, where we can have a paradoxical observation with, let's say, good control in the third trimester. But I think both of them contribute.
Right. Well, thank you to both presenters for really excellent presentations and your insights into this topic.